progress, so we should be good.
Okay, so it's recording, and you have access to the presenter. Okay.
Okay, great. Awesome. Thank you so much, Dominique. Dominique is here representing the Sickle Cell Consortium and Lakia, so thank you so much for handling this for us this evening. And thank you all so much for joining this evening. So really quickly, I'm going to tell you all who we are. Dr. Ekman and I, we work on a project called REDHHOTT that focuses on finding and helping educate folks on ways to reduce complications from blood transfusions. So that's everyone from people who are living with sickle cell disease to medical providers that help treat people who have sickle cell disease. So we provide education to all of those different communities, and we collaborate with the Centers for Disease Control and also organizations like the Consortium. So today we're going to talk about keeping it safe, iron overload. Dr. Jim Ekman, like I said, will be facilitating this conversation. We do really encourage you all to please ask questions throughout the session tonight. Just write them into the chat box, and we will get to all questions. Just a friendly reminder that if you have a question about your own personal medical history, that you should always take your questions to your medical professionals, your doctors, your nurses, whoever you see on a regular basis. Make sure that you ask those questions to those folks as well. Okay. So, like I said, we're talking about keeping it safe, iron overload. We'll talk about what is iron overload. We'll talk through problems that are caused by too much iron from transfusion. And then you'll also have the opportunity to learn. There's a little background noise, so Dominique, if maybe you could mute all, or people on the line could mute themselves. Perfect. Thank you. Okay, so
credit they take, like if you don't have to pay like that 1123 or whatever.
Dominique. Dominique.
I'm sorry, I'm trying to see who it is.
A little bit of background noise. Again, if you would please.
I hear.
His name under hers because he has like.
I'm sorry, I self-muted everybody. I can't see who it is.
Okay.
Give me a second. I'll find out which one it is. Please, everyone, if you can hear, please self-mute.
Yeah. So when you pay rent, do you pay it to her? No, I pay it to.
I think there's a Sheila on the line. We can hear your conversation. If you don't mind muting your line, please.
Okay. Yes. Sorry.
Okay. Thanks, Sheila.
Yes.
Okay. So I'm just going to move right along and hand it over to Dr. Ekman so we can get started with our conversation tonight.
Hello, can you hear me?
Yes.
Okay. Can you see my screen?
Yes.
No, it was still my screen. So, Dominique, you'll need to pass the presenter mode to Dr. Ekman.
Just a second, let me.
Okay. You're now the presenter, Dr. Ekman.
Oh, wait a minute, just a second. I'm gonna. 1 second here. Okay, can you see my slides now?
Yes. Yes.
Okay, but I couldn't pass it on, so just a second. I'm going to have to rapidly go through all of these. Sorry about that.
Okay. We're doing a rapid version.
Okay, now we're getting there.
Okay,
thank you. Finally. You can see the slide that you just had up and my points
Yes.
moving?
Yes.
Okay, great. We're good to go. So tonight we're going to talk, continue to talk about transfusions. And the first session we talked about all of the good things that can happen. The second session we highlighted some of the problems related to developing antibodies when you get transfused. And tonight we're going to talk about one of the more important things that happens with individuals as they get lots of transfusions, and that is they develop iron overload. And I'm going to go through that in a little bit of detail to tell you what that's all about, and then also to really highlight some ways that you can participate in your care so that if you are getting regular transfusions, you can really reduce the chance of having problems from those transfusions. Again, we mentioned that transfusions are really important. They're the most effective treatment in sickle cell disease, and they work in many situations to prevent emergency problems, and also can be given chronically to reduce the chances of having long-term problems. The two reasons that we give transfusions in sickle cell are to raise the hemoglobin level, so that helps get more oxygen to the blood, because the more hemoglobin you have, the more oxygen there is in the blood to get to the tissues. The second very important thing that happens in sickle cell disease is that the normal cells are very flexible and can get into the small blood vessels where they can give up their oxygen. In sickle cell, traffic jams occur, and by giving transfusions of normal cells, you can dilute out the sickle cells and get blood flowing again so the tissues get enough oxygen. So it's the single most effective treatment for many of the serious complications we see in sickle cell disease. Regular transfusion prevents complications like stroke, acute chest, can prevent pain episodes and other complications. Virtually anytime you get a transfusion, if you're weak or short of breath, you'll feel better after the transfusions. Many have argued that perhaps we should transfuse everybody with sickle cell all of the time, and that would prevent occurrence of any problems in sickle cell disease. But I'm going to go into the second major reason we don't do that in a minute. I'm going to stop now and ask if there are any questions. Ashley, have you got any questions? I can't see any screens. Can't hear Ashley. I'm going to move.
Oh, I'm sorry. Now? Can you hear me?
Yes.
Dr. Edmond? Okay. All right. There are no questions in the chat box, but I do have a polling question that I'd like to ask the group.
Okay.
So, Dominique, if you wouldn't mind giving me the presenter mode again so I can ask that question.
I'm doing it. Give me 1 second.
Okay. Well, we're already running a little behind schedule, so we can just move forward, Dr. Eggman.
I gave you
okay. Were you able to
you have it. Yep.
Okay. Okay, everyone. So the folks who are on the computer, in a moment, you're going to see a question to show up on your screen, and you all have 2 minutes to respond. So please respond to this question. The question is, why should a person not get a transfusion all of the time? This is something that we reviewed in the last course, so let's see if you all remembered what Dr. Ekman walked us through last time. So why should a person not get a transfusion all of the time? That's the question on the screen. And this is a multiple answer question, so there could be more than one correct response. Dr. Ekman, the responses that I have listed on the screen are: it can potentially cause iron overload, it can put a person at risk of developing antibodies to transfuse blood, or C, it can make crisis pain feel worse. So those are the three options to that question. Most people have answered A and B, excuse me. And it looks like everyone has responded. So most people said A, it can potentially cause iron overload, and B, it can put a person at risk of developing antibodies to transfuse blood. There were a few people who answered C, it can make crisis pain feel worse, Dr. Ekman. So I don't know if you want to maybe talk about that also. But
okay. Can you give me back the controls?
Yes, Dominique. So Dr. Ekman is going to go over
Dr. Ekman has control now.
Okay, thank you.
You're welcome. Dr. Ekman, you have control.
Okay, thank you.
You're welcome.
So why don't we transfuse everybody all of the time? And we've gone over this before, but there's a good side and a downside to transfusions. And when we give transfusions, we have to balance the good and the bad, and we only do things in medicine, or try to only do things in medicine when the good effects greatly outweigh the bad effects. And the answer to the question is shown here. The reasons we don't transfuse everybody all of the time is that we have trouble with iron overload, and we're going to talk about that tonight. Transfusion reactions can occur, and that's related to developing antibodies to the transfused blood. And then finally, there's still a small risk of passing infections on with a blood transfusion. Things like AIDS and many other infections have virtually disappeared in transfusions, but occasionally people still get hepatitis C from transfusions. We have stressed in previous talks that the transfusions during an acute pain crisis probably don't shorten the pain crisis and really don't have a role in trying to treat the pain. But C was not a correct response because there's no real evidence that transfusions will cause the pain to get worse. Okay, I'm going to skip the questions here because we've really are a little bit behind schedule. So let's talk a little bit about iron overloading. And why is this such a problem? Well, the first thing is that there's a lot of iron when you get in the blood when you get the transfusion. Hemoglobin is red because there's 4 molecules of iron attached to each of the hemoglobin proteins, and when you get a transfusion from anybody, you get about 200 milligrams of iron. So that's a lot of iron. To put that in perspective, when you eat a good meal every 3 times a day, you get about 2 milligrams of iron during the day. And so the amount of iron in blood is very, very substantial. The other thing that's very important is that the body has evolved in an environment where it's very hard for it to get enough iron. Iron is very critical to a lot of the functions of the hemoglobin, the muscles, the heart, and a lot of the systems in the body that are used to generate energy. So it's a critical nutrient that we need but our diet is very marginal in iron, and so the body has developed ways of getting holding on to it as best it can. Dr. Bailey did a really nice little discussion that I believe is posted on the website that you should look at, that talks a little bit more about iron and how it is transported in the body and held onto. Now the picture,
Dr. Edmond, I'm
yes.
sorry to interrupt, but we cannot see your slides.
You can't see
Dominique, the WebEx shows that I'm still the presenter, so Dr. Edmond needs to be the presenter so we can see his slides.
Okay, just a second.
Let me change it back. Hold on. Dr. Edmond. Yes.
Okay, now Dr. Edmond is the presenter.
Okay, let me try it again. I hope I'm in the same place I was. No, I'm not. Just a second. I may have to, I'm going to try and jump ahead, but nope. Okay, just a second. You're all going to get dizzy. Yeah, there's no way to advance it other than doing this. I'm sorry.
That's okay. We still don't see your slides, so.
You don't?
No, we don't see your slides. You have to share your screen, Dr. Edmond.
I thought I did, but let me try it again. I guess it didn't transfer back.
Okay, there we go.
Now we can see it.
Yes, now we see your slide.
Okay, let's see. Now I can't advance it. I'm going to have to take that down and put it up again. Oh, this is horrible. Can you see my slides now? Are we flipping through them?
Yes, we are.
Okay, I'm sorry. That's the only way I can do it. I tried to jump ahead and it doesn't work.
No problem.
Ashley, can you save the last poll until after we're all done?
Yes.
So this doesn't happen again. We'll just go through it continuously. Okay, let's.
Okay.
So the way I like to think about iron and iron overload is shown in the little picture. And iron is absolutely critical for making machinery that's necessary to run the world. But when the iron interacts with oxygen, it gets oxidized. It forms rust. And in a machine that's got lots of iron in it, the rust sort of jams everything up so the machine stops working. Well, the same thing that happens in the body when there's too much iron around. The iron that's in the body reacts with oxygen, and it damages the proteins and lipids and sugars in the area, sort of causing rust. And that rust jams up the mechanisms of the body so that they can't function normally. And so the hemoglobin doesn't function as the way it should when it's oxidized. The muscles don't. And then very important, other organs are damaged. It doesn't take very long to get iron overloaded, so that after you've had about 20 or 30 units of blood over your lifetime, you'll have too much iron in your body. To put that in perspective, if you're on a regular transfusion program and get 2 units a month, which is kind of an average amount of transfusion if you're getting it on a regular basis, in 1 year you'll have too much iron in your body, then we have to do something about it. Iron damages the liver, the heart, the pancreas, and hormone glands. Individuals who have too much iron can develop difficulty with their liver and heart, and can have diabetes and other hormonal problems from the iron. One of the real concerns about iron that we have is that we looked at our young adolescents who were transitioning from pediatrics, and about half of those individuals were dying of iron overload very early after they came into our care. And so not only is this a serious problem in terms of damaging the organs, but this can lead to very premature death. Once you have too much iron in your body, it's relatively difficult to remove the extra iron, and we're going to go into that at the end of the evening. So how can we avoid problems with iron overload? Well, I think the first and most important thing is not to get more transfusions than you need. Certainly when you need a transfusion, when you have a serious complication that requires transfusion, or your hemoglobin gets too low and causes you to have symptoms, then it's a good idea to get a transfusion. With certain complications, you should go on to a regular transfusion program, like if you've had a stroke. But one of the things that we really want to emphasize is that we want to avoid unnecessary transfusions because they can lead to trouble with iron overload down the road. One of the things we've stressed under alloimmunization or forming antibodies to blood was it's very important to keep track of those. The other thing for preventing iron overload is very important is to keep track of how many units of blood you've had over a lifetime. And you should have a health journal or a passport, and you should record every single transfusion, when you got it, where you got it, and how many units you got, and then also record if you've developed any antibodies. And that can be a very good record that you should keep with you at all times. This shows the old-fashioned way of doing it with paper and pencil, but there are also electronic ways you can do it now, so you can keep it on your cell phone and always have it with you, so it's readily available to refer to and to show to your doctors and other healthcare professionals that you're seeing. And by keeping track of the amount of transfusions you get over your lifetime, you can get a very accurate idea of how much iron you have in your body. Can we skip the polling question here?
Yes, we can skip it.
Yeah, we'll do it at the end. So what else can you do to avoid problems with iron overload? Well, I think the other thing that you really want to do is when you've had a significant number of transfusions, I'd set that number at about 20 units over your lifetime. It's really important for you to keep track of how much iron you have in your body. And this is something that every 6 months or year or so, you should ask your healthcare provider, what is your iron level, and help you get an idea of whether you might have too much iron in your body. Are there any questions to this point before I go on?
There are no questions in the chat box.
Okay, I'm going to go forward then. So how do you measure iron? Well, one of the more accurate or most accurate ways we have is actually to total the total number of units you've been transfused over your lifetime. And that's been shown actually in a number of studies, not in sickle cell disease, but in another disease, thalassemia, to really be a good way of tracking iron. You can also, so you can just keep a number. And I think that it's very important that individuals with sickle cell who are getting transfused and their healthcare providers really do keep careful count of the total number of transfusions you're given. There's a very easy and inexpensive blood test called a serum ferritin level. that also can give a good idea of how much iron there is in the body. And this is something that we track, and it really can be a sign that an individual is starting to get too much iron. And this is done usually once a year in people that are getting in frequent transfusions, and maybe twice a year if somebody's on a regular transfusion program. The serum ferritin isn't perfect, but it does give you an idea when you're starting to get iron overloaded, and may want to do some other tests to see really exactly how much iron is in the body. The old-fashioned way that we used to think was the gold standard for measuring iron was to actually take a biopsy of the liver using a needle and analyzing the liver for how much iron is present. And this would give us a very accurate assessment of how much iron there was in the liver, and that really showed how much iron was in the heart and other parts of the body. That is not done as much anymore because there's a new way of doing it using MRI, and you can put an individual into an MRI unit and use a special set of calculations, and the MRI can calculate how much iron is present in the body. And this is becoming a much more accurate way of assessing it in the body as a whole, and it also can check the iron level in your liver, your heart, your kidneys, and your pancreas, and so it can get more information than just doing a liver biopsy. And that's sort of now becoming the gold standard for how we measure iron overload.
Dr. Ekman,
Yes.
Ekman, I'm sorry to interrupt. We do have 3 questions I think would be important for us to clarify before we move forward.
All right.
The first question, Monica wanted to ask you, did you say no more than 20 units of blood in a lifetime? She wasn't sure what you meant when you were talking about the 20 units of blood.
No, that isn't a limit on how many transfusions you can get. That's the number that when you've reached 20 units, then you have to start thinking about the fact that you might have too much iron, and it has to be measured to determine that you don't have too much using the ferritin or one of these other techniques that I've just talked about. So it's not a limit, it's just when you start having to worry about the fact that you might have too much iron. Is that clear?
Okay.
Yes, that's clear. I've had an exchange once or twice in my life. I was just wondering.
Okay. Yeah, no, that's not an absolute limit. It's just where we start thinking about the fact that somebody might have too much iron.
Okay. And the next person wanted to know, is 1 unit equal to 1 bag?
Yes, exactly. That's a unit, bag, and sometimes people still use the old term pint of blood, but those are all really what we mean by a unit of blood. 1 bag, 1 pint, 1 unit.
Okay. The next question is, what is the threshold of ferritin level that is considered iron overload?
Well, so when I use the ferritin to start to determine whether somebody has too much iron, I usually would use a level of about 1,000 micrograms per microliter as sort of a threshold when I'd want to do another test to see if somebody was iron overloaded. So 1,000 usually doesn't tell you for sure they're iron overloaded, but when it reaches that level, then I would go ahead and use another one, either a liver biopsy or an MRI to really determine how much iron is present.
Okay. The next 2 questions, really quickly. This person says their daughter receives transfusions every 5 weeks to prevent reoccurring stroke. She's trying to determine if they want to look at other options to prevent stroke. The question is, are there other options or are transfusions the best options for stroke prevention? And again, before Dr. Eggman answers this question, we do again encourage you all to talk to your medical professionals when you have specific questions about your medical history. So Dr. Eggman.
So the answer to the question is that the transfusions given on a regular basis are really the best way to prevent a recurrent stroke that's available to most individuals. There are other options to think about. If somebody has a bone marrow transplant donor, that is also an option for continuing to try and prevent strokes. And so instead of giving transfusions, if a person had a donor and had a history of strokes, we would strongly consider going ahead and having a transplant done in that individual. There is some suggestion that hydroxyurea might offer some protection against recurrent stroke, but that protection is minimal, and most individuals really don't feel that hydroxyurea alone is adequate for stroke prevention. So transfusion is really the best way of preventing a recurrent stroke. Transplantation, if available, is the second best, and then if for some reason an individual couldn't have a transplant or be transfused, then one might consider using hydroxyurea, but that would be a poor third choice.
Okay. Dr. Eggman, there are two more questions. Would you like to respond to these now or to go forward?
I would like to respond to them because I'm going to talk a little bit of how we treat iron overload in a minute, so let's answer the questions and then we'll go on.
Okay, sounds good. So the next question, patients who are on scheduled transfusions, are their iron levels routinely measured? Are providers not automatically providing iron-binding medications to prevent iron overload as a proactive approach?
I hope so. That's really what we're trying, part of what we're trying to accomplish with the REDHHOTT project, to make sure that we're educating both health professionals and individuals and their family members on what the proper way of getting transfusions are, and secondly, what the best way of managing and preventing complications are. So we're educating health professionals in parallel to make sure that they understand that iron overload is a very serious problem. It requires to be monitored carefully, and then when it's documented, the individual needs to be treated aggressively for the iron overload. So that's the ideal world. Certainly, I think there are physicians that do transfuse and aren't paying enough attention to the iron overload, and that's what we're trying to correct with this project.
Okay. The next question is, my daughter has had negative TCDS since receiving them. She has iron overload and is on desferal. I spoke with her doctor, and I believe it's starting to take long-term now. DMT to be exact. Is desferal effective? I think her question is, and I may be pronouncing this wrong, desferal effective to this medication?
Desferoxamine and desferal are the same thing. So yes, those are the terms for the same thing. So the only way I really can't answer that question directly. I think that gets into managing your individual child's medical problems, and without having much more information, it would really be inappropriate for me to answer that question. I would really suggest that you have a long conversation with her healthcare providers and discuss some of the options. There are other options available, And that you should have that discussion, and if the answers aren't really adequate, you're not satisfied, I would suggest that you get a second opinion from another sickle cell expert just to make sure that she's getting or he's getting the optimal treatment.
Okay, that was the last question for now, Dr. Edmond.
So let's go ahead and talk about treatment, and we've sort of touched on it. And I'm not going to talk in detail about this, but I really want to talk to you about some of the approaches we can use. Now, one of the best, because there's a lot of iron in blood, one of the best ways of getting rid of it is to actually draw out units of blood if the hemoglobin level is high enough. And so that's called phlebotomy, or bloodletting, and you just bleed the blood out. And if you do it slowly and take a small amount at a time, you can remove very large amounts of blood, iron, through phlebotomy. This is usually available only after a bone marrow transplant has cured sickle cell disease and the hemoglobin level is perfectly normal. Some individuals who have been on chronic transfusion programs in the past have been transferred over to hydroxyurea when this has been used for something like chronic anemia or recurrent pain crises, and somebody's getting transfused for those. If they're transitioned over to hydroxyurea daily, sometimes the hemoglobin level can actually get high enough so that they can have phlebotomy and remove the iron overload that way. And that was shown in a recent study where hydroxyurea was used instead of transfusion in individuals who had a positive transcranial Doppler but didn't had never had a stroke. And in some of those individuals, they could actually remove the iron by phlebotomy after hydroxyurea. Erythrocytophoresis that we talked about, where when you get transfused, a equal volume of red blood cells, sickle cells, is removed at the same time. And this can certainly slow the rate at which people get iron overload and sometimes prevent it completely. And it's often used along with chelation therapy to remove the iron from an individual more effectively. And then finally, there's chelation therapy, and there are a number of drugs that can be taken daily to remove iron from the body. And these drugs bind to the iron and they pull it out of the tissues, and they allow it to be removed either through the kidneys or through the stool. And I'm not going to talk about the names of the drugs, but there really are three main ones that are available. One is given by slow injection. It requires an infusion of a medication in the vein or under the skin for 8 to 12 hours every day. There's one that's an oral solution that's taken by mouth, and there are two that are pills that are taken by mouth. All of these treatments are effective and can be used to control the amount of iron in the body, and can be used to remove iron when there's too much in the body. The problem that we have with these chelation drugs is that they're hard to take every day, and individuals who are iron overloaded really don't follow instructions and don't take their medication the way they should. And so even though it's being prescribed, they miss doses, they don't do the infusions for long enough, or they just don't take the medication at all. And so if you do need medicine for iron overload, it's very important that you take the medication exactly the way you're instructed to take it. You do it every single day if that's the way you're supposed to be taking it. And that is the best thing you can do. And I really would encourage the warrior group to take on iron overload and encouraging people to be really conscious of how they take their iron overload medication. There is a disease called thalassemia where iron overload is also a great problem. It's also a genetic hemoglobin problem. And young adults with thalassemia formed a group called the Thalassemia Action Group. And they actually were very successful in using peer pressure and mentoring to get young individuals with thalassemia to take their medication. And I would hope that the warrior group would also take this under their wing and really make this a priority as something that should be encouraged, because many children now are going on to transfusion programs for strokes, for positive transcranial Doppler, and for other reasons. And maybe upwards of 10 or 15% of sickle cell patients are going to have trouble with iron overload as they get to be adults. And it's very important that we address adherence to these medications so we can manage this correctly and prevent their bad outcomes. So I'm going to stop there and answer any questions. Even though we started a little late, I think we're going to end a little bit early, but I would certainly like to try and answer any questions that are out there.
So Nicole has a question about, I guess, a reference that you just made. She asked if what you just mentioned, is that also known as an exchange transfusion? So that was maybe 2 slides earlier. Exactly,
yeah. The erythrocytophoresis and exchange transfusion are the same thing. We talked about that last time, and those are exactly the same things. Both of them, exchange transfusion, can be done manually or using the machine, and when it's done by the machine, it's called erythrocytophoresis.
Okay. Thank you for that question, Nicole. The next question is there a change in color of body fluid, like urine or feces, when taking Desferal?
Yes. In fact, that can be occur with other chelators too, but certainly with desferoxamine, it will change the urine orange. That's perfectly normal. It's just a sign that the iron is coming out, and it's not a problem, but it does change the color of the urine.
Okay. That was a great question. Thank you. The next question is, can you get iron overload while on apheresis?
Yes. You can. The iron needs to be monitored with exchange or apheresis, but you still can get iron overloaded. It usually is slower, but it is not perfect on giving back and taking out the same amount of blood. So it slows the rate at which you get iron overload. It prevents counting the number of total units as being an accurate way of monitoring it, so you have to use the ferritin, or better yet, periodic doing the MRI determination of iron. But it's slower, but it does not completely eliminate the problem with iron overload.
Okay. The next question is, are there any additional precautions you recommend for patients taking Jadenu? I'm sorry, I'm mispronouncing this. Jadenu? Jademu?
So really answering that would be beyond the scope of this presentation. That's really a discussion you should have with your your healthcare provider, because it really depends on the dosing and the administration schedule. It's very important to go over the side effects of the medications and some of their other effects so you understand them, and that's a discussion directly with your healthcare provider.
Okay. Are there any other questions from the group? And is there anyone that called in and you didn't log in through your computer, and maybe you have questions if you only called in? Okay, I think that's it, Dr. Ekman.
All right.
I would like to just really quickly do that one other poll question, if you don't mind. And then we'll still give people, feel free to continue asking your questions while we pull up this last poll. Dominique, can you please change the presenter mode?
Ashley, I can do that. Are you going to be
that?
the presenter, or should it go back to me?
Yes. Yes, if you could change it to me, so change it back to me. Yes.
Okay.
Yeah, and Dr. Ekman, while Dominique is doing that, there's another question. Can iron overload be fatal?
Yes, it can. I've had a number of patients who have died of complications of iron overload.
Okay, Ashley, you have presenter mode.
And you all please feel free to continue asking questions. While we pull this up in just a moment. Okay, so same question. Why should a person not get transfused all the time? I'm going to open that up, and if you would please respond to that question. You guys are moving fast. Thank you so much for responding so quickly. Okay. So, Dr. Ekman, while people are responding, there is another question.
I'm sorry, Ashley.
And again, so Monica, Monica on the line, but has her phone unmuted.
Yes, I unmuted everyone, just in case the people that are on the telephone wanted to ask a question, because they were muted on my end, so I had to unmute them.
Okay.
So please, everyone, self-mute yourself unless you have a question. I just muted Monica, so I will unmute Monica, just in case she has no, but I believe Monica's on a computer, so she could do it as well.
Oh, okay. Okay.
All right, so I unmuted everybody.
Okay. Thank you, Dominique.
You're welcome.
Dr. Ekman, the next question is, should patients watch their iron intake when consuming food?
No, that really isn't necessary. The amount of iron that you get from the food is small in comparison to the amount you get from transfusions. And so that really doesn't significantly cause problems in individuals with sickle cell disease. If you're on regular transfusions, you probably don't need additional iron like by vitamins or any supplements, but certainly the amounts that are present in the food won't cause any problems for somebody with sickle cell disease.
Okay. The next question, Dr. Ekman, is Is Desferal the best drug for iron overload?
The desferoxamine or Desferal is the most effective way of removing iron, but each of the drugs that I mentioned, the classes of drugs that I mentioned, really have positive and negative aspects. And so the problem with Desferal is it has to be given by injection. The other medications are taken orally, and so it's much more it's much easier to take them, and so adherence is better. So they're effective also. So depending exactly on your clinical situation, many of the drugs may work for you, and that's again a discussion that you would need to have with your healthcare provider to go over the various medications and which one would be best for you. It also depends a little bit on where the iron is, and there's many other factors. So a discussion with your healthcare professional is really the only way to determine which one would be the best for you if you need the medicine.
Okay. All right. We have another question. We have two more questions. I'm going to open the poll really quick. The next question says, you should ask your doctor to test your iron if you have had more than 50 units of blood, 20 units of blood, or 5 units of blood. This is a question directly from Dr. Ekman's presentation tonight. So let's see how many folks respond. So, Dr. Ekman, you'd be happy to see or know that most folks responded 20 units of blood. So we have some active listeners here tonight.
Excellent. Thank you.
All right. So we do have two more questions. I want to make sure we get to those as well. I know we're coming up on time. I think we're right at 7:30. So for those who can stay on for a few minutes more, Dr. Ekman, are you open to answer the last few questions?
Yes, I am, certainly.
Okay. So if you can stay on for a few more minutes, we'll respond to these last few questions. So the next question is 1 bag of whole blood equal to 1 bag of RBCs, or it takes more than 1 pint donated to get the 1 pint of red blood cells needed?
No, the amount of red cells in a whole unit of blood and in a unit of packed cells is about equal. They're very, very similar. So there's the same number of red cells in both a whole unit of blood and a bag of packed red blood cells. And the amount of iron is the same in both of them.
Okay. Okay. Okay, we have about 3 or 4 more questions. Dominique, I am going to ask if you wouldn't mind muting everyone's line again. I don't think the folks on the phone have a question, and it's a little bit of background noise. For people who are logging off, I do see a couple of folks that are logging off. Just a friendly reminder that we do have another session this week on Wednesday at 6:30. We will be having a special guest from the American Red Cross who will be talking to us about how to host a blood drive. I know a few folks have specially requested that. So we'll have someone from the Red Cross. Dr. Ekman and myself will be here again, and we will talk about the importance of African American blood donation and some strategies to help you promote any blood drives that you decide to plan. So that's on Wednesday at 6:30. Okay, so, wow, the questions are really coming in, Dr. Ekman. The next one is, are any of the currently available chelating medications limited in access to patients who are insured with Medicaid?
Yes, I believe they are. One of the ones that I talked about actually isn't approved for use in sickle cell, so that would not be available for Medicaid patients for sure, unless they paid for it themselves. So yes, and again, you'd have to talk to your social worker. Most of the companies that make these medications do have programs for individuals who can't afford their medication, and very often you can get the drugs that way if they're not available through your Medicaid or insurance. So that would be a question for the social worker that works with your healthcare professionals.
Okay. Next question. Is it common for patients who start getting transfused as kids to go into adulthood continuing the transfusion? Do they have greater complications or organ damage due to the fact that they began transfusions at an early age?
So yes, as we talked about in the first lecture, if you've had a stroke, the evidence is that you need to stay on transfusions for your whole lifetime. So children who transition to adult care should be maintained on transfusions unless there are other factors. And the earlier you start the transfusions, the more iron you're going to accumulate over the years. And so individuals who started earlier are going to have more trouble with iron overload as they get older.
Okay. The next question is, how low or what's the normal range for the iron level?
Do you mean the ferritin? Yeah, I can't go into the specific iron levels in the different tissues.
Yes.
Generally, somebody who has a ferritin of less than 20 is iron deficient. Usually, if their ferritin is over 100, they're normal. And when the ferritin gets over 1,000, that's when I start worrying about iron overload.
Okay. The next question is, if I'm a person that can donate blood but have been deferred for 6 months to a year due to ferritin issues, is this a sign that I have low iron? Question is related to donors between the ages of 16 to 18.
The main reason for being deferred is the fact that your hemoglobin is too low, and that's usually related to iron deficiency. But if you've been deferred repeatedly, you certainly should see your doctor and have studies to determine exactly why your hemoglobin level is too low. So that would be something that you would need to talk to your doctor about and have testing. The first thing I would do in that setting is to do a ferritin to see if that is the problem. But if the ferritin were normal, then you'd want to look for other reasons for the hemoglobin being low.
Okay. Ulysses asked a question. I don't think I understand it exactly, but maybe Dr. Eggman, you'll understand when I read it. Is the most effective drug based on the level of iron? I think that's what he's asking, or this person is asking. So is the most effective drug based on the level of iron?
The answer is generally yes. The amount of iron and where it is located would tell how you would use the medications. And so each of the drugs has a little bit different effectiveness in removing the iron and does it in a different way. So there are other factors other than just the total iron level that have to be taken into consideration, including how well the heart is working, how well the liver is working, how well the heart is working, and how well the kidney is working. And that has to do with how the drugs are, how effective they are in getting the blood out of the tissues, but also in the ones that go out through the kidney need to have good kidney function, and the choice of drugs might be different if somebody had problems with their kidneys. So it's a very complicated answer to a complicated problem, and that would be one where you'd have to have a discussion with your doctor to determine which one would be best for you.
Okay, Felicia had a follow-up question. She asked, is 300 safe? She's referring back to a comment you made earlier. Is 300 safe? Felicia, maybe if you want to just give a little bit more detail with that question so we can respond.
I think that's a question for her healthcare provider, because that depends on a lot of different factors. Yeah. Without knowing your whole history, I couldn't really answer that, and a lot of your other blood tests.
Okay. All right. We have 4 more questions, Dr. Eggman. Do you have some more time? Should we take these last 4? Okay. All right. Thanks you all for these really great questions. This next one is, what objective clinical markers are used to evaluate the effectiveness of hydroxyurea?
So my most important way of evaluating hydroxyurea is to determine how it makes the individual feel. So if you're taking it and having more energy and less pain, then that's fine. You don't need any other effects. I also want to follow the hemoglobin level and the fetal hemoglobin level and try to determine if those are getting better. And then I look at the white count, the platelet count, and the average size of the red cells to determine if we should give a higher dose of the hydroxyurea or not.
Okay. Is the most effective chelation drug based on the amount of iron in the liver?
No, it's based on both the amount of iron and which organs it's in. So some of the medications are more effective at removing iron from the liver, others from the heart. And so that's based on the amount of iron in each of the different organs, but it's also based on how well each of the organs are working. And so you have to balance that, because, as I said, the drugs that go out in the kidneys need good kidney function, and one of the medications that take the iron out in the stools might be more effective if somebody's kidneys weren't working real well. So it's a very difficult problem of balancing exactly where the iron is in the body, but also which organs are functioning best to get it out of the body once the drug binds to the iron.
Okay. The average amount of blood is usually 2 units a month. Is this an average for all warriors or just those on routine transfusion?
Pardon me? I
Okay,
couldn't hear
this person asked, can you hear me?
Yeah, now I can.
Okay, this person said the average amount of blood is usually 2 units a month. Is this an average for all warriors or just those on routine transfusions?
The average of 2 units is generally for somebody who's on a regular transfusion program for stroke prevention. All of the other reasons for getting regular transfusions would have different amounts of blood requirements, and some people can get by with a unit or 2 every 6 weeks or 2 months if, for example, they're being transfused because their bone marrow isn't working well enough, they may not need 2 units a month. That's usually the schedule that an adult ends up on if they're getting the transfusions for stroke prevention.
Okay. Okay, the next question, Dr. Ekman. Okay, why do ferritin levels fluctuate so much month to month?
Okay, that's a very good question, and I said the ferritin is a relatively good way of measuring iron, and the reason for that is it's affected by many, many different things. First of all, if you have an infection or any kind of inflammation like arthritis, the ferritin goes up. If the liver is being damaged, the ferritin goes up. And if you're on therapy, chelation therapy for your iron overload, the ferritin goes up and down very wildly. So it's a very good test to start determining when you have to worry about maybe having too much iron. Once you decide that there's too much iron in the body, and especially if you're on treatment, then it's not as useful, and the MRI or liver biopsy have to be used to determine exactly how the iron treatment is going.
Okay, and I think this is the last question, unless there are others. If the only option is Desferal, does it mean that it's the most effective?
No, it might mean that it's the best choice because of other side effects or other problems that you have related to the other medications. So in many settings it's the best choice, but because it's so difficult to administer, many times the oral medications are used instead, but that really depends on whether you've had reactions to the other medications. And as we've talked about, every treatment we have has side effects, and sometimes the side effects prevent you from getting those medications. So then you might have desferoxamine as your only option, Desferal. Okay. Okay, Dr. Eggman, I think that was the last question. Someone left a comment. She just said that her daughter receives 3 units every 5 weeks, but she did not have a question. She just wanted to make that comment. So that was the last question, Dr. Eggman. Okay. Thank you very much. Thank you, everybody, for such great questions. It really was a good session. Thank you all so much. Please come back on Wednesday when we talk more about African American blood donations, and we have our special guest from the American Red Cross. Thank you. Good night. Bye-bye.